Special test real quick, and then so why don't you lay down. We'll just start with the straight leg raise. So this is technically part of the neuro exam. Have your patient just relax with their giant army boots on. Nice loose leg. You're going to lift the leg, and you're trying to elicit if they have pain in the sciatic nerve with 30 to 70 degrees range of motion. Okay? That's simple. They may have pain on the ipsilateral or contralateral side. Both are suggestive of herniated disc. Okay? All right, what's next? Knee. Okay? How do we start with the knee? What's the first special test? The Balakman, right? So we'll start there. So if we start just our inspection, we're looking at the suprapatellar bursa, right? So that's how we're going to do the Balakman test. It's shaped like a horseshoe or half a donut, whatever your reference point is. You're just going to squeeze down on that suprapatellar area and try to assess for fluctuance of the patella, right? So it should feel the same when you do that as when you push the fluid under, okay? Then what? Varus and valgus stress, right?
So, I have a question though.
Yeah.
What's the difference between the bulge sign and the balloon sign, like physical exam wise?
Bulge sign and the balloon sign?
There's like other features.
So
it was in the patient, yeah, it was in base.
The bulge sign is when you're looking for the bulging of the infrapatellar bursa, right? So it looks like a dumbbell on either side of the inferior fold of the patella. And you can milk that away and then push it back down. You can just see if the fluid's there, okay? So those are tests you're going to do if you don't have an obvious effusion. If somebody's got a really huge effusion, you should be able to see it. You know, they're going to have a real prominent bulge above the patella or that kind of dumbbell shape below it. Okay? So for varus and valgus stress, just cup your patient's heel in your hand. And for, which is the bad one? This one. This one. Okay, so we're gonna. Okay, you're gonna push medially with your hand on the knee, and you're gonna pull laterally. Okay, and then for the varus stress, you're going to do the opposite. So you're going to push laterally at the knee and pull towards you at the ankle. So which one's more likely to be injured? Medial, right? So typically the external injuries, you know, football, soccer, who knows, other things that they're going to drive the knee medially and more likely to rupture that MCL. Okay? Lateral collateral ligaments are usually associated with more aggressive injuries, more likely to be associated with additional pathologies. Okay. Then what? Drawer, right? So drawer, we go onto the other knee, so I don't hurt you. So 90-degree flexion. You can sit on the foot. You can put your knee on it, and you're just trying to pull the tibia toward you. So just put your thumbs on the tibial plateau and just pull toward you. You want to make sure your patient has relaxed hamstrings because the hamstrings are going to inhibit that translation, right? So they're stabilizers of the tibia. We go to the Lachman. I'll do it on this side so you can see. Hands in this position. So thumb should be just below the tibial tubercle. Okay. Up here, he's got big legs. Good luck, Nora, on this today. Okay, so you're gonna push downward here, and you're trying to pull the tibia towards you. Okay, again, nice loose hamstrings are key. You're gonna rock it back and forth like that. Okay, posterior drawer. Sorry, I didn't do that one. Just the opposite of the anterior, just pushing dorsally on the tibia. Anything else for the knee?
Are these going to be like painful if the ligaments partially torn? All the ligaments?
They can be, sure. So the Lachman may be painful right away. After the knee is blown for a while, it might be less uncomfortable. McMurray. Okay. So there's lots of different ways they describe these in different books. The simplest way is to bring your patient into flexion as far as they can go, and then you're gonna internally rotate and extend. Okay? The direction of the foot is the opposite compartment that's gonna be stressed with the test. So when you're internally rotating, you're assessing the lateral meniscus. Okay? Then you go back up into flexion, externally rotate, and come down, and you're stressing the medial compartment. Okay? Last thing is the ankle drawer. You can do this sitting, you can do it in the supine position. Cup your patient's heel in your hand, and you're going to try to pull that forward while you're stabilizing the tibia. Okay, so you're dorsally displacing the tibia and pulling the heel forward. Okay? And that's it.